Welcome everyone. My name is Steve Mombach and we're proud to be giving a TriHealth Facebook Live session for skilled nursing homes and home care. I am our Senior Vice President of Ambulatory Care. I have been with TriHealth for 17 years. I have been in the skilled nursing industry prior to that for over 20 years. We're thrilled you could join us today, and we're really proud of our relations that we have with the nursing homes out there. As many of you know, TriHealth has had a long-standing commitment and relationship with our post-acute providers. Over the past 20 years, we've had educational events and symposiums, and through the last 4 years, we really have updated that to ensure we are communicating on a regular basis, sharing best practices in healthcare, and that's been provided by Lori Baker and by Barb Dam. We also have learned a great deal through these conversations. We appreciate the ongoing collaboration and mutual focus on your residents, many of our patients, and their families to ensure that we truly give the best possible care as we serve together in Greater Cincinnati. The past 3 months have certainly been challenging for all of us, and the community really has come together and have worked together, and hats off to the healthcare collaboration that have brought together our local hospitals, skilled nursing facilities, and home care organizations to ensure that we're all learning and adjusting to the challenges that have been presented with COVID-19. Our sincere appreciation to Dr. Richard Chunk, the Health Collaborative team, and all the local industry leaders that have done outstanding work in keeping everyone organized and proceeding ahead for what could come. TriHealth wants to spend the next hour or so answering questions that many of you have already submitted. So we're so appreciative of our two physicians that are joining us today. Dr. Kevin Joseph is our Senior Vice President and Chief Medical Officer for TriHealth, and Dr. Stephen Blatt, who's our System Chief for Infection Disease. Both are participating with this live event, and we're just thrilled to have you both here. Dr. Joseph, why don't I allow you to just ask some comment and offer some comments on what is the status of COVID in our community and some of the trends that you've been seeing?
Sure. So we are pretty unique, or done a fantastic job in Ohio as it relates to COVID-19. At one point, we were expecting on a single day in the peak of COVID for us to have several thousand individuals inside the hospitals COVID positive. On our peak in this region, we ended up having about 350 patients. So what Governor DeWine and Amy Acton did was really fantastic, and it really blunted the curve. And we were way over prepared, but at least now we've had a dry run for in case there is any increase over the next several months. Some people also thought that there would be an increase, a wavelet or a little mini spike after we opened up bars and restaurants and gyms. We have not seen that yet. We have the normal fluctuation and indulation of the number of cases, but TriHealth itself, which is a large healthcare provider in this community, actually serving 1 in every 3 Cincinnatians, we're at the same level we were several months ago, and actually a little bit lower. And so it's going very well. The doubling rate, which is the number of cases on one day, how long does it take for that number to double? So how long does it take to go from 2 cases to 4 to 8? And originally, our number of cases diagnosed in Ohio in this region was doubling every 2 to 3 days. Right now, we're at a rate of every 31 days. So you can tell a big difference between how quickly it's spreading before and how quickly it is occurring now. I do have a graph, perhaps we can show later, called the R factor. The R factor is reproduction factor. And what that means is if I'm infected, how many other people am I going to affect? Am I going to affect 1, 2, 3? And if you're affecting one person, that means it's a steady state. The COVID-19 pandemic isn't growing and it isn't shrinking. If it's greater than 1, that means I'm affecting 1.5, 2, or 3 individuals, then it's expanding. If it's less than 1, then it's contracting. We have these 8 regions in Ohio, and we're region 6, I believe it is, and all of the counties within all the regions are shrinking so they're less than 1, except for one of the regions, and that region is further up north, near Dayton and a little bit north of Dayton. But Cincinnati region, we are at a 0.8. And so the number of people infected is actually shrinking. The pandemic is shrinking right at this time in Cincinnati. It is still around. It will be around for a while, and we can talk more about the duration at some point further in time.
Good. Well, that's great news, and my message to everyone listening today is keep up the good work, because it's all of the people out there in the community that are taking the precautions that they need to do. If one of their patients comes to one of our physicians or a physician in the community, or they have a diagnostic test taken at one of the hospitals, MRI, CT, do you recommend any type of isolation or quarantine when they come back from that appointment?
Well, thanks, Steve. I'm Steve Blatt, Medical Director for Infectious Diseases for TriHealth. I've been here at TriHealth for a little over 25 years. At this point, there's no need to quarantine residents when they return following an appointment in an office or for a diagnostic test. All of our hospitals are extremely well cleaned now. Everyone is screened on entry into the building, and all of our healthcare workers are universally masking. And I think it would be very safe for a resident to either have a physician appointment or come in for a diagnostic test and then go back to their regular residence when they return.
So you don't feel like then when that resident returns they need any quarantine or anything like that because they were out in the community?
No, I don't think so. I mean, all of our transportation people are universally masking and being checked on a daily basis as well. I think the system is very safe right now.
Great, thanks so much. Next question was if there's mandatory testing or random testing for employees and they take a PTO for COVID-19, what do we recommend when they come back?
So for employees who are ill with COVID-19 or even those who are asymptomatically tested positive, they should be off for at least 10 days, and they should be afebrile for at least 3 days before returning into the work environment. Those are the Ohio Department of Health regulations. Those are the CDC recommendations for healthcare workers who are ill from COVID-19. So we call that the 10+3 rule. 10 days since symptom onset or 10 days since the first positive test, plus 3 days afebrile, and their clinical symptoms should be improving. They can return to work. They should obviously always be wearing a mask anytime, just a regular surgical mask anytime they're in clinical care. But they do not need follow-up testing as long as they have fulfilled that 10 days since symptom onset and 3 days without fever.
What if they're just going on vacation and they're going out of state? Is there any kind of recommendations in regards to testing before they come back to work in those kinds of situations?
Yeah, there's no recommendation for testing. The CDC does recommend if you've traveled internationally that you perhaps should quarantine for 14 days upon return, but every kind of employer and every state is different in those recommendations about whether they mandate that quarantine. So I think you have to be cautious about international travel.
Okay.
Someone has been out taking PTO for COVID-19, they were positive. So they're infected, they're quarantining themselves, staying at home. I think some of the question was when they come back, do we test them and how frequently do we test them? And we don't. And here's the reason why. When someone is infected, all the studies that come out so far, and maybe more, and update me if I'm wrong, but the most recent studies stated after 10 days that it's not possible at this time that we know of to actually collect live virus from someone, from the nares is the most sensitive. So if we test someone who's been infected 10 days or later, we're not going to be able to collect live virus. However, the test will still be positive. The test is so sensitive, it's picking up very small particles of RNA, of the virus. And so you can actually be tested positive up to 4 to 6 weeks later, but it's dead material that's still in your nasopharynx, so it hasn't gone away. So it can send some false signals of, were they positive because they still have a positive test? No, because after 10 days, the virus is dead. Now you're just collecting some samples of dead virus.
Dr. Blatt, the way you answered for MRI and coming to a physician office, does that also go for dialysis? For patients that are coming to dialysis, then returning to nursing home, the same basic?
Yes, same story for dialysis centers. The dialysis centers are all being very cautious. All of the employees are universally masking. They're all doing extra cleaning. And I think for residents who require dialysis, they can go right back into their normal living situation.
Right. Great. And I will say your questions are coming in. That dialysis question was one of the questions that came in, so keep them coming. The next group of questions are from caregivers. And the question goes, if I'm wearing the proper PPE and following proper infection control techniques, what is the likelihood that I will catch or transmit the virus?
Yeah, I would say the likelihood is extremely low. If you're wearing all your appropriate PPE, washing your hands on a regular basis, and doing social distancing as much as you can in a workplace, that the risk is extremely low. I think the risk is much higher when you're out in the community at Kroger's or going to Home Depot. I mean, as I'm sure all of us have seen, a lot of people in the community are not wearing masks, they're not using social distancing, and hand hygiene is difficult to do out in public sometimes. So I think most of the risk of transmission of COVID right now is not in the healthcare system, it's outside of the healthcare system in routine community settings.
Gotcha. What are the suggestions for reassuring families of other patients that live in the same wing as that, and maybe someone next door is positive? They're nervous that their loved one lives next door. What are the odds that the patients, do you have to isolate that patient? Are they a threat to those other rooms? There's a lot of stigma out there about that.
Yeah, so I think in an independent living situation or an assisted living situation, as long as there's no physical contact, that they're not sharing the same dining areas, as long as they are staying in their own living quarters, that the risk should be minuscule of any transmission. The virus does not go down the hall, it doesn't go under doorways, it doesn't go through the ceiling. Physical barriers like walls and doors are extremely effective in preventing transmission or movement of this virus from one place to another.
If you put it into a kind of a different perspective, there are thousands of people across the United States and then probably in Ohio who have been positive, and so they quarantine themselves, but they're living with other people at home, the spouse, the children, and so they don't rent an apartment somewhere or a hotel. They stay at home and they just keep to their own room, and they actually share the same kitchen and whatnot, whatever the processes they've developed in the family, and the other family members are not becoming infected. And so, and that's happening all the time. So this is kind of an example where actually we're in a little bit more of a controlled setting in a skilled nursing facility than actually at home, where people are traveling perhaps to the same bathroom or the same kitchen.
Great. So one of the questions we had came in, if someone has a 93-year-old relative who lives alone and is considering moving to independent living or assisted living, should they hold off right now? Any reason not to continue living at home, or is it safe to go ahead and transfer them into one of the assisted living or independent living residences?
I'll take that. It's living at home. It's always, I think, best anyways for someone. It's more comfortable oftentimes. But if someone wants to go into assisted living, then I wouldn't have any hesitation sending my loved one to an assisted living facility. All assisted living facilities in this region have done just a fantastic job keeping up with the current status and keeping clean and the different protocols, and partnering with acute care facilities like ourselves and experts like Dr. Blatt. And so I really wouldn't have any hesitation. It's, as Dr. Blatt stated, is more likely to catch COVID from going out to Kroger and Home Depot or just walking around any other public area than it is going to a skilled nursing facility.
Good. The next group of questions is about PPE, protective equipment that our staff should wear. And the question is, and they want to comment about the N95 or equivalent mask, what's better, what about gowns, gloves, face shields, and I really am, and I want to say this for our organization, really proud of our organization that we've been able to donate a lot of equipment that nursing homes have and home care have needed. Our team has done terrific that way, and we will keep doing that for the community. But comments on, I think there's a concern, I have to have an N95, the only way I should do it, and we know there's some misnomer on that. So I'll ask one of you Dr. Blatt, maybe for you to comment on that one.
Okay. Yeah, so when you're caring for a patient who's known to be COVID positive, especially during that first 10 days of the infection when we think they are able to transmit the virus, if N95s are available, that's great. Regular surgical masks are also very, very effective in preventing transmission from an infected person to a healthcare worker. N95s are slightly better, but certainly not 100% better by any stretch. There's a slight reduction by using an N95 mask. Gowns and gloves, especially when you're doing on-site direct patient care, as well as a face shield or some kind of eyewear to prevent transmission into mucous membranes like the eyes are essential as well. And so by using that kind of personal protective equipment, we've been very effective in preventing transmission to healthcare workers. And so I think if those kinds of PPE are available, healthcare workers can be very confident that they're not going to pick up the virus from an infected person.
Great. Go ahead, Dr. Joseph.
Another thing in terms of perspective, so the CDC, as Dr. Blatt stated, recommends that healthcare providers, when they're working with a patient who is COVID positive, to wear the face shield and the gown and the mask, but it's just a surgical mask. And as a provider myself, when I'm with a patient listening to the chest or inside the throat, I am just a foot or two away from the patient. And the CDC still only recommends a surgical mask. So someone just around the room wearing a surgical mask, the chances drop dramatically whether you're going to catch it. And another precaution you can take is when a provider is in the room of a resident or a patient, have the resident or patient put on a mask, and that will help out as well. And as Dr. Blatt stated, if you do have N95s, this is just another layer. And so each layer of protection does add further, but really what is needed by the CDC is just a surgical mask and then something to cover your eyes.
All right. Okay, the next question has to do with caregivers and working on the units. And being in the industry, I know that very often we work short-staffed, there's call-offs, and the question is, if a care worker works in a COVID unit on Monday, and then they have a new assignment on Tuesday in a non-COVID unit, there's a belief that they can transmit it that way. And can you just comment on that, going from one unit to another, whether it's even on the same day or whether it's the next day for those caregivers out there?
Yeah, I mean, I think as long as you're wearing your PPE and doing good hand hygiene between patient interaction and being screened on entry into the workplace every day, there should be no problem caring for COVID patients on one day or non-COVID patients another day, or even on the same day caring for COVID and non-COVID patients, as long as you are using all your appropriate PPE, using exquisite hand hygiene, and being tested when you come into the workplace. The risk of transmission will be exquisitely low.
And if I can add that, because the next logical question is, so Dr. Blatt, if that's true, then why are hospitals having a COVID unit? Because they don't go together. Well, actually, the reason why we have a COVID unit is more for efficiency, as well as training. So if all the COVID patients are on a unit, then all the staff, the nurses, the PCAs, everyone that's going in has additional training on how to don and doff PPE. It is very important. Taking off PPE isn't just a process where you just rip it off. There is a process. So the more a certain set of individuals are using the PPE on a day in, day out basis, they become experts. And so it's just safer to have those experts in one unit versus patients all over a hospital, and now you have to train thousands of staff instead of that core staff. So it's really more for efficiency than it is to protect other patients throughout the hospital.
Okay, great. So next question is the one that probably even I want to hear your answer on, about a vaccine. You know, do you see it over the horizon? So much conflicting information on it. Just any thoughts that either one of you have on a vaccine?
Yeah, so we can talk briefly about that. So currently there are about 8 to 10 vaccines in clinical trials in the United States and throughout the world. So they're doing phase 1 and phase 2 studies where they make sure that the vaccine develops an immune response and that it's safe. The phase 3 studies will really be the ones that will determine which of these vaccines gets out into production, and those phase 3 studies will determine whether it's effective in preventing transmission of the virus to uninfected people. I think the vaccine studies so far are going very well. Anthony Fauci at the NIH is hopeful that we'll have at least a good vaccine candidate by the end of this calendar year that can start going into production, so that early in 2021 we may have a vaccine that could be rolled out to the general public. There's a lot of work to do in the meantime, but really that's the way we're going to get through this pandemic, is with a vaccine that can protect uninfected persons.
And actually, Steve, you got an email the other day from a local company who wants to have 10,000 Cincinnatians enrolled in a vaccine trial. So you may be hearing more about that coming up in the next couple of weeks.
Yeah, and we'd be excited to somehow help them if we could help them get this going. As he mentioned in his email, you know, Cincinnati was the home for polio, and getting that solved, and wouldn't it be great if we can make some contribution to that. Next question that we have is how the virus living on surfaces. What is the likelihood that I could contract the virus on a hard surface, on an elevator button, on a door handle, especially if I'm washing my hands as required?
Well, I think two things. The first is that this is not a hardy virus. It's really a very wimpy virus. So even though they can find little bits of viral material on hard surfaces sometimes, the CDC has stated that they don't think that virus is very infectious or is mostly non-infectious. So the main way that this virus is transmitted is through respiratory secretions and not so much on hard surfaces. And that's the whole point of doing good hand hygiene. If you happen to touch something in your workday, which you're going to touch lots of things in your workday, if it happened that there was some virus on that surface, as long as you do good hand hygiene, you know, before taking care of each individual patient like you should, there should be no risk of transmitting it through hard surfaces and hands.
If I can add something as well, if you just think about the process of contracting the virus, someone would have to sneeze or breathe on an object, and virus doesn't live long on objects. A certain amount will live longer. Cardboard is a couple days. Metal is determined to be just a few hours. So they have to get enough of the virus onto that object that then the virus has to live on that object. Then I touch it, and then I need to also then touch my mucous membranes. So there's a lot of ifs, and so that all has to go really well. And then even if you do all of that and you touch your eyes or nose, just because there's one virus in your finger doesn't mean you're going to get infected. You still need a certain load of virus, amount of virus, for you to become infected. And so a lot of ifs, and that's even without washing your hands. So now you wash your hands, and it just decreases dramatically.
Right. Then the question, and we may have gotten to this, but I'll ask it because it was asked. We talked about viruses in the rooms, and you know, one room to another, and the question was, can the virus move under cracks in the doors or outside a patient room, especially if you're doing non-aerosol treatments that are being performed or anything else? So what's our thoughts on that?
Yeah, it should not be able to move under the cracks in doors or through solid partitions. The only time that we worry about that in the hospital is when we're doing something called aerosol generating procedures like intubating a patient or doing bronchoscopies, but those are not things that would occur, in a skilled nursing facility setting. So in a routine skilled nursing facility setting, physical barriers are a great way to prevent this virus from moving from one place to another.
Right. So the next question's a little controversial, so I'm going to tell you all that TriHealth doesn't like getting into controversy. We respect our governor. But the question goes, the governor has asked for testing of all nursing home staff through the National Guard. And they are doing that. We know through the collaborative work that Lori Baker and I and many on this call are on. And they're picking and choosing the various nursing homes with the goal to go through all nursing homes. How does that fit in with the 10 days off, 3-day ephemeral recommendation to return to work if we're not going to retest? What's our thoughts on this recommendation, as we would only be testing at a certain point of time, and basically the community is open to business, so you test Tuesday during the day, Tuesday night now you're out at a restaurant or you're downtown walking around. Give us some thoughts on that one.
I'll start,
Yeah,
and
go ahead.
Ed and Steve. So your thought process behind it, I think, is right on. And that's the same reason why people say, well, why don't you just test healthcare workers on a regular basis? Well, is it every day? Is it once a week? Is it every other week? And when does it stop? We have 13,000 healthcare workers at TriHealth. So that's a lot of testing, a lot of manpower, a lot of efficiency for when you get a result, what are you going to necessarily do about it? In the general population of Cincinnati, only 1% of people are infected and asymptomatic. And now is even a question of, if you're infected and asymptomatic, are you even contagious? Can you infect someone else? And now there's evidence saying, no, you really can't, because you're asymptomatic, and yes, you're positive, but you're fighting it off at the same rate as trying to grow inside of you. So even if you're asymptomatic, it's not going to do much. Now, some of this effort, I don't want to say the reason why they want to test individuals in nursing homes, maybe just epidemiologic. What percentage of patients in a nursing home are infected? So we start to do some epidemiologic studies in the community. We've already done a lot in the community. New York has done a whole ton out in New York, but they've been hit harder. So this may be part of that. I'm not certain of what the thought process in Governor DeWine's mind. But Steve, what else do you have to add?
Yeah, I think that's exactly it. So we know that that persons living in nursing facilities are at very high risk for bad outcomes if they do get sick with COVID. And I think the state wanted to see what is going on in nursing facilities, how prevalent is asymptomatic infection, and is there evidence that healthcare workers that are asymptomatic in that setting can transmit the virus to their residents. I think a lot of this came out of the time before we were universally masking, before we knew how this virus was transmitted so easily within nursing facilities. But now that we have all these precautions in place, I would expect we're going to find, there are some asymptomatically infected healthcare workers in nursing facilities, but they are not transmitting the virus to their residents because of all of the things we've put in place in the last 6 to 8 weeks. I think all this came out early in the course. Just today in the New England Journal of Medicine, there was a big publication about that nursing facility in the state of Washington where the disease spread very rapidly, but that was before we knew the disease was even in the community. So you have to look at when these studies were done, and if they were done before we had all the precautions in place, it's not surprising that it spread quickly.
And we know that the nursing homes have certainly, one bad apple then goes to every nursing home, which we know isn't fair, but it's the reality of a lot of what the nursing homes live with. But the one thing I want to comment and have you both comment is we need the nursing homes to take care of some of the positive patients that are not sick enough that they need to be in the hospital beds, because we need to ensure that these hospital beds are free for the people that truly need it in the future. Help the audience understand that setting up these units for the positive patients are a good thing that we needed, and help explain the goodness that they're doing and what some of the precautions they can take in order to fulfill that mission.
Absolutely. and that's what's lovely about the partnership that TriHealth and I'm assuming other healthcare organizations have with all the skilled nursing facilities and other places of residence, is the partnership going back and forth. And we're doing a lot of work to improve in communication between the different organizations. But yes, in addition to what Steve was saying about if we just keep all the patients for 2 weeks as they're positive, or 10 days, and inside the hospital, we'll quickly become overwhelmed. Not only that, but it's not as good for the patient, for the resident. When individuals inside the hospital, they don't get up and ambulate as often. They start to get some psychiatric issues at night and the sundowning. Because they're not up and often, there's more up as often, better chance for getting ulcers, for getting DVTs, thrombosis, for getting pneumonia. So the closer you can get the patient to a home setting, the better. And a hospital is far from that.
Right. Dr. Blatt, any?
No, I would completely agree. It's always better to keep the resident in the setting that they're used to. There's going to be a lot less issues with delirium, a lot less issues with the kinds of infections or complications that are in a hospital setting. So keeping residents in their own environment is always better. And so I think the residents would appreciate it as well. They don't like coming into our hospitals. They don't like being isolated in a single room where people aren't able to visit them very often. So I think having a unit where they can reside, or a space that's their own, would be much preferable.
And then Dr. Joseph, anything that you can help our nursing homes tell the other families of these patients? Because the families are the ones that get so nervous. Oh my goodness, you're taking care of positive, my loved one's not positive. What are you doing? How would you help them understand? And by the way, I have a 94-year-old mom that lives in California in a nursing home, so I think of these things myself too.
Sure. Just even going back on what I was saying earlier, that if the precautions are taken inside a nursing home, skilled facility, similar to if I was infected at my own house and undergoing precautions to make sure my family doesn't get infected, the chances are really quite low. I would not have any hesitation sending my mother or my father, who fortunately are still with me, to a nursing home. If they needed that care, then I wouldn't hesitate. It's the best place for them. They can't stay at home, and then for certain whatever reason is, and the hospital is certainly not a great place for them. Actually, because it can make things worse.
Good.
Yeah, I think the key is families should make sure that whatever facility they're choosing for their loved one, that they have precautions in place, that all the healthcare workers are using masks, that they have hand hygiene available everywhere, that those persons that are COVID positive are not out in the general population with the rest of the residents. And as long as those isolation precautions are in place, I think it's very, very safe.
Yep.
The audience, how do we know that 1% are asymptomatic and positive? What population was tested to make this hypothesis?
That's a great question. That question popped up within a couple seconds of me stating the 1%. So this is how we know that number. As we opened up acute care, healthcare, to elective surgeries, what was recommended is if someone needs an elective surgery, let's test them before the surgery for a couple reasons. One, if someone is in the early stages of being COVID positive, we don't want to go put them on a ventilator, because that just adds a risk to them. Ventilator is not a benign thing. In addition, when you intubate someone and put someone on a ventilator, that is an aerosolizing procedure. So we want to know if that person's positive. So every patient that's coming in for the elective surgery, they don't have any symptoms, and we test them. So just TriHealth has tested a couple thousand patients. And over those couple thousand, 1% of those asymptomatic patients who are coming in from the street are positive. Across the region, because we collaborate really well through the Health Collaborative, there's, tens of thousands of patients that have been tested, and all of the healthcare systems are seeing the same 1% positive rate in the community.
And the next question that someone wrote in is some of our team members and people live in smaller homes with other family members, and they need to socially isolate if one of the members becomes positive.
Here's my thought. I'd love to hear what your thoughts are too, Dr. Blatt. The more you can separate, the better. right? If you can stay 6 feet, perfect. 12 feet, 15 feet, whatever it is. When you're living in the same environment, it's a little more difficult. You may be using the same bathroom, you may be using the same kitchen, but the same precautions go into place. If as much as you can, stay 6 feet apart. Keep washing your hands because you're not going to contract it, as we talked about earlier, just by touching stuff. And then also, if you have surgical masks, you can get them at stores. I think you can now get them at stores is enough. Everyone just wear a surgical mask. And the chances are quite low if you do all that and have good hygiene. So is there a chance? Yeah, it's just a chance of getting a flu. But actually, I think this season flu, to go on a tangent, is going to be much less because everyone's going to be taking precautions anyways for COVID-19, and you catch COVID-19 the same way you catch the flu. But what are your thoughts about individuals living together in smaller
Yeah, I
houses?
mean, I think as long as you can stay in separate rooms and isolate within the home as much as possible, people should be fine. Probably a lot of the transmission that occurs in a home setting is before people recognize they are coming down with COVID. So the first day or so of their symptoms, am I getting sick? Is this an allergy? You just don't know. They're still being exposed to everybody in the home, and that's when the transmission occurs. Once you know that you got COVID, I think the transmission risk goes way down as long as you're physically separated as much as possible in that setting.
That's a good point.
Good. And team members, there's also talk, and I think some of it's happening, of testing some of the nursing home patients. And if a nursing home patient is tested positive, or someone in AL, do they have to go to the hospital? So the test comes back, they're positive, they're feeling okay. Do they have to go to the hospital?
I'll combine a couple of thoughts that we've already stated. Unless they need the hospital for the acute care, it's not a good place for patients to be. Hospital's there for when you really do need the service. If not, and we're not providing much of a service, then there's actually risk of delirium and ulcers and DVTs and pneumonia. So no, I wouldn't send them, and especially if they're asymptomatic. Still keep it isolated and put a mask on them if that's possible. Some people have lung disease where you can't. Wash your hands, and the chances are still very low. One, because you're taking the precautions, and two, the new research is coming out, which I stated earlier about asymptomatic patients. There's a good chance that they are not contagious. Steve, what would you add?
Yeah, I would agree. The more that the resident can stay in the surroundings that they're used to, the healthcare workers they're used to, healthcare workers know that resident and know if they're getting sicker or what's going on, we can always get them transferred to the hospital if they deteriorate. And I think staying in their normal environment is by far the best for them as long as they're medically stable to do that.
You know, a lot of the nursing homes and assisted living, they've started to allow visitation of family members. A lot of it's happening outside, but some of it's happening inside. Any recommendations on advice that we give to family members that are coming to visit, or for the nursing homes that are watching, on what they can do? A lot of these loved ones have been without seeing their families for 3-4 months now. What is your advice on how the family members should dress up? What can the nursing homes, assisted living do to welcome and set up the right environment to keep everyone safe?
Yeah, so I think as long as the visitors are wearing a mask and that they're screened when they come in for symptoms and perhaps temperature screening if that's available, and then also as long as they are doing good hand hygiene before they have any physical contact with their loved one, I think that will go a long way to reducing any transmission from visitors to residents. It's got to be incredibly difficult to be a resident in a nursing facility and not have any family contact for that long of a period of time. That is really, really hard. And I recognize why that was important because of the high-risk people living there. But now that we know that at least in this area, the pandemic is slowing down and that only 1% of asymptomatic people might be shedding virus in this area, I think the risk is incredibly low as long as you're putting those precautions in place.
You know, Steve, everyone has their own level of comfort with this virus. My family, my sister is a little more on the paranoid side. My parents, they're very cautious, they're doing the right things. My sister stayed at my parents. I just stay inside your house. Don't want you going anywhere. I'll send you food and don't touch the mail. And my mom looks at my sister and says, well, but we don't know, when is it going to end? Is it going to be a year and a half, 2 years before? What am I supposed to just bunker myself out? You want to live a life. And if it is another year from now, year and a half, unfortunately, that could be the life expectancy of some of these individuals. So, my recommendation is just take the right precautions. And it must be terribly hard, as you stated, Dr. Blatt, of not being with family. And it helps them in so many ways.
Yeah.
So you just take the right precautions.
We've heard a lot through our different nursing facility partners of the great things that they have been doing to facilitate communications, of using Facebook, of using where the recreational therapist is bringing the patient to the window so they can see their families. And now that they are doing the outside types of options for visiting, they're having to put a lot in place of helping to make sure they have team members going out with the patients to ensure that everybody is washing their hands, keeping social distancing. So our nursing facilities definitely want for patients to be able to be with their loved ones. They see the importance as well. It's definitely a huge emphasis in the conversations, and we're seeing a lot of creativity and a lot of great work on their end to help make sure everyone stays safe as we move to this next iteration of managing the COVID and allowing people to start visiting one another.
Speaking of outside it's very difficult, in my opinion, to contract COVID-19 unless you're really right in contact with someone. It's an open air environment, more air circulating, as well as COVID-19 doesn't like UV light. UV light kills it very, very quickly.
Yeah. I told my mom that, one of these days I'm just going to get on a plane and visit her in California. And she said to me, before I even think about it, she wants to know that her hairdresser can do her hair and that her nail lady can do her nails. So I'm not allowed to come out until either one of those things are done. I think one of the last questions we have, and if either one of you has the answer, you'll get a big prize. How long can we expect the COVID crisis to last?
Is it under over? Go for it.
Yeah, under over, yeah. So it's going to go on for at least until we have a vaccine, and then, it will depend on the vaccine effectiveness and how many people are willing to take it. Some recent surveys I've seen, only 60 or 70% of people are saying they'd be willing to take the vaccine. I don't know if that would be enough for us to get herd immunity within the community to stop the transmission of this virus. So we may be dealing with COVID indefinitely. Hopefully a lot less likely to transmit it if we have a good vaccine. But this virus, I don't think, is going to go away. It's not going to be like MERS, where it just disappears from the face of the earth. It's going to be around for a long, long time.
And I would add to that, and I think you stated earlier, I agree with your predictions about a vaccine. I think and hope there is one that's developed and approved by the end of the calendar year. Then they're going to start making it and then providing it to individuals, and that's going to be another 4-6 months. So I'm hoping Memorial Day next year we can take off these masks. That's my dream.
Right.
Yeah.
Great. Well, listen, Dr. Joseph, Dr. Blatt, thanks so much for being with us today. To our audience out there, you truly are heroes. We consider you heroes right next to our hospital workers. And thank you for everything you do in the nursing home, to the home care providers, to dialysis, to all the different units out there. We know what you're doing, we know what you're facing, we know the challenges you have, and all we can do is say thank you. We truly appreciate your efforts. Should you have any questions in the future, feel free to email myself, Lori Baker, Barb Dam. All of us here at TriHealth are willing to assist you where we can. And with that, we'll say have a wonderful weekend and enjoy some nice weather. Thank you.